Evening all, wherever you might be. My name's Dirk Pilat, and I'm a GP in the currently utterly scorchio, Essex. And I'm the medical director for professional development here at the RSDGP. Tonight, we're going to do something new, something we haven't done before. We're going to talk about healthcare transition and how we in general practice can help young people with often complex and life-limiting health problems to step into the often very strange world of adult healthcare. The webinar tonight has been 2 years in the making and has been the result of cooperation from our friends from Together for Short Lives, a steering group full of amazing academics, GPs, and carers. And today, after 2 years of meetings and research and literature reviews, we've launched an amazing set of e-learning resources that you will be able to access via the RCGP's learning environment. So please check it out afterwards and tell your friends. Tonight's speakers will be the authors of the 2 e-learning modules. That's our friends Mike Miller and Peter Lindsay, my colleague Toshita de Silva Amara Sequeira, who worked very hard to get this project underway, our friends from Together Short Lives, Lizzie, Julia, and Hannah. And because we really have only an hour and a really full program, let's start with our first speaker. Dr. Mike Miller is a retired consultant pediatrician and wrote the first part of the e-learning module. Mike, can you please share your screen, introduce yourself, and off we go.
Hello, I'm very pleased to talk to you tonight on a problem that I've known about for at least 40 years. So I would like to talk about the transition from children's care to adult care. It's something that, as I say, we've been battling with for a long time. Paediatrics doesn't do it very well. Adult care doesn't do it very well. And it causes parents and children an enormous amount of problem and anxiety. There's a nice slide here of a young man who, when we were talking about transition and how it had gone, explained the complications. It was kind of, when did I become an adult? And he was saying when he was 17, he thought to be an adult by the NHS because he couldn't access the children's wards anymore. Social services were absolutely certain he was a child because he wasn't over 18. And of course, adult education thought that he was an adult and should behave himself. So it's really difficult to know when you become an adult and when you should transfer. And so the module that I've done, the first part, talks about definitions of those children who have particular problems. I think it's transition into adulthood is difficult for anybody, but it's particularly difficult for children with life-limiting and life-threatening conditions. So there's a bit of talk in the module about definitions, and I won't go into that too much tonight. I will talk about the size of the issue, the existing evidence about how well it's done, and that's not very well at all. And then I'll talk about legislation guidance and the pathways. And in the first module, it's based on the case of a child with severe quadriplegic cerebral palsy. And as the module goes on, it takes her through various stages in her life. So I'd like to say that actually general practice recognizes any change is difficult. And I guess that's when patients tend to present to you, or general practice can help people through those changes. And usually the transition from a child to an adult is positive, as well as having some difficulties. Having had 3 children who are children no longer and have children of their own, it can be difficult for all involved, but it's a positive experience. But for those children with a life-limiting or life-threatening condition in their families, the change from paediatric to adult services can be very challenging. You're looking after your child, certainly for a child with severe quadriplegic cerebral palsy who has limited capacity. At what point are you able to relinquish parental responsibilities? And that's almost never, nor does the child ever gain autonomy. So it's a real problem. It's a real worry transferring your responsibilities over to others. And it's a problem which is increasing. There's been a lot of good work using discharge data from hospitals, looking at all ages in children, and identifying the numbers of children with life-limiting, life-threatening conditions that we now consider to be kind of palliative and uncurable. In 2001, the incidence was 17.6 per 10,000, and that's gone up to nearly 50 per 10,000 in 2017, and is likely to continue to rise. It's not just due to better coding, a little bit is due to better coding, but an awful lot is due to better quality of care, more use of technology, the increased ability to look after children at home, and hopefully they are surviving with a good quality of life, and that's the aim. And of those 50 per 10,000 young adults, 85% are going to need an organised transfer to adult care. That is, they've got needs that need help and support, that they need some transfer of care. And actually, secondary care is not very good at doing that. But for any individual general practice, it's actually, perhaps you'd only have 2 or 3 young people recognisable or you'd be aware of until you perhaps go searching and you look a little bit further. And general practice is the one service that will look after these children or potentially be there for these children and families right from cradle to grave, as the NHS promised very early on. So some of the difficulties, so SCAL is actually primary care physicians in America, but it's very applicable to this country. And he recognized some of the difficulties when he did a study in 2002. And adolescents and their families' resistance to transition. They liked being under the care of the paediatricians. They were well known to the children's ward. They could, they're perhaps stars on the children's ward. So they didn't want to move themselves. They didn't see why they had to. There's a lack of institutional support. There wasn't the process. There wasn't the pull from the adult services that seemed to welcome them into adult care. There's a lack of time, because when you're engaging with these families who've been known about the illness and have managed the illness for a long time, it does take time to get to know the families and to meet their expectations. It's very different from a new case coming along. There's certainly a lack of reimbursement. It's just not recognised in funding streams to fund this at all. And then there's also the difficulty of communicating with specialists. That's partly the paediatricians who don't want to let go and therefore aren't communicating, and perhaps the adult services who don't want to take these children on, who don't communicate very well, perhaps. A more recent study, 2018, and this is only 2 of many studies which have looked at the problems of transition, showed an ongoing dependence on paediatricians. And I think that's well recognised in this country. The GP general practice refer to paediatricians. The paediatricians say, oh, if there's any problem, come and see us. Just ring the ward up. And the general practice gets sidelines, and paediatricians have got to get better at involving general practice. And general practice is perhaps got to get better at putting their hands up and saying, this is what we can do. There's an inadequate communication between the providers and the patients. And that's perhaps not being honest about what happens when you turn 18 and you can't come to the children's ward. And also for those who are the managers and the funders of the health service, there's a reluctance to take on these complicated cases and fund them in the adult care. And as I said before, lack of confidence in primary care. The parents have come to see that their case is very difficult and complex, and they feel it is beyond primary care, when actually very often it's not. It's straightforward. Certainly all of those are issues for the case described. The parents didn't like the child going to hospital into paediatric care, but they were terrified of going into this young lady going into adult care and how adult services were going to cope. There are a number of legal structures, and when you look at it, there's some really well-intentioned work that has gone on. The Mental Capacity Act, I think, has been an enormous benefit in adult care, but it's stuck at the mark of when you're 18, you become an adult until otherwise proven. So that at that point, parents lose their parental responsibility and they become a very important person to be consulted in the care of their child, but they don't have that overall power that parents have for a younger child. The module goes a little bit more into Gillick competence. And there's that patient data confidentiality. How much capacity does a child have for you not to tell the parents about what they need to know? Pediatrics is so much easier because you just act on the best interest of the child. And we used to continue to do that into early adulthood. You struggle now, and that's very much each individual child, each individual family. There is useful guidance from education and social services. So they had a very organized Special Education and Disabilities Act that got very good structure, so that on the whole, social services have a process that doesn't suit all families, but they do have a process. And in particular, they stipulate the local authorities must ensure education, health and care plans should be reviewed at year 9, which is when the young person is age 14, and then every review thereafter. And unfortunately, that review often involves education and social services, but it doesn't involve primary care, and only rarely might it involve adult secondary care, in fact, almost never. But it is at that point where they are thinking about transition and what the child is going to do after education. And of course, for most of us, our children will go off into work and make their own way in the world. These children are still dependent on what do you do with them every day, that the parents need to have a structure to move into. So the families often find that their unique local situation, it doesn't fit into local services, and what's out there for them isn't what suits them. There are a number of good published pathways. I have got 2 here. The one on the right is a transition pathway, and you can find others very similar to this. This is from the National Network of Parent Carer Forums, who did some very good work on what a good transition looked like, and that's mentioned in the module. Together for Short Lives, and you'll have a short talk from there a bit later on. They do some excellent work, and there's a really good tick sheet, check sheet for those who are transitioning that is very useful to go through with the parents. And general practice doesn't need to provide the answers, but I think it needs to provide a listening ear and just support that actually in the end it will be all right. But then here's nice guidance: ensuring transition is strengths-based, lots of good words. But actually in practice, it's really difficult to carry that out, and parents won't see it that way. So my final slide is really, I think there is definitely a role for general practice. I'm delighted to take part in this study. I was initially involved in the interview panel looking at the funding and offered my services because I was so pleased that this was going to take place. And I think the general practice has got a real role to play. It is a process, so you can get involved at kind of any time. It does need to start early, and that age of 14, when the children are going through reviews, is good. And it will involve some planning, but it doesn't necessarily need to take an enormous amount of time. But it certainly needs that general support and interest, and that carries over time. And knowing that the general practitioner will be there at the end of that journey for the families will be very useful. So I look forward to your questions and comments. Thank you.
Thank you, Mike. You know, it's so lovely coming from somebody who's worked for so long in secondary and tertiary care. I really miss the days when we could pick up the phone to our local pediatric consultants and know who we had on the other line. But it's really reassuring that somebody in pediatrics actually agrees that this is something we can take on and we can take and we can do well. And I really think that general practice has a role to play, and we've been doing it for all our professional life, probably without knowing that we're actually having a process, because it's just something that comes natural to us. But it's probably even a better idea that we are starting to look for these patients and starting early. Okay, Peter, start.
Right, I am Peter Lindsay. I've got quite a long experience of working in two large practices, and I have just completed a 30-year, 3-month contract. That is, it was a 3-month contract in general paediatrics, doing outpatient clinics. So I've looked at both sides of paediatrics, both in general practice and in primary care. What Mike said, all of it has to be accepted. It's true. And I won't go over the points that he's made, but we have to be able to cope with the transition. It is basically an inevitable process, which we either cope with it or we see crises. Mike's explained why. But I think the other thing we need to stress is that the young people particularly affected by long-term conditions, whatever they are, whether they're diabetes or the long-term conditions that Mike's been discussing, they are going to be affected by socio-economic disadvantage. And in this country, given the circumstances we are in, if you don't start off with socio-economic disadvantage, once you're disabled, you will have socio-economic disadvantage. The thing is that we have, in general practice, we have coped with change. We've coped with all these changes and we have done them very well. We've done them actually better than anybody expected. I started off in a practice in the 80s where we had an immunisation rate of 15%. By simply setting up a register and a designated clinic, we got the immunisation rate up to 95%. We can do it. Next, please. But so what do we need to actually help young people undergo the transitions that Mike's described? And the first thing is we need to understand them. And as Mike said, he's seen 3 young people in his own family through from childhood into adulthood. But he's had relationships with them from infancy into adulthood. We need to prepare ourselves on how we're going to cope with young people coming in to see us for the first time. Now, the best way to avoid and avoid difficulties is for us to become more and more involved in their care before the time of transition. Now, nice guidelines and all the guidelines that say, right, transition should occur or start off between 11 and 13 or some number. The plea is we need to get general practice to be more involved in paediatric care from birth. If we did that, we would reduce the 5-a-day tragedy, where 5 children a day die in this country more commonly than in Sweden because we do not have community-based expertise in childcare. We need to change the training so that all practices, but we can't do that overnight. So what can you do? You can go back to your practices and you can educate, motivate, and organise. You can stress to them what Mike has told you, that there are increasing numbers of young people with increasingly complicated disabling conditions that are entitled as much to an adulthood as any other person. And we need to help them to get an adulthood. We all say, well, for every child, a childhood. Well, for every adult, an adulthood. And that includes those with disabilities. To do that, we need to motivate the practice. As Mike says, there isn't funding for this, but we need other ways of motivation, even though there's COVID to cope with. And we need to organise. And the way we need to organise is we need to change the way we have our medical records. We don't need the medical records of children to simply be prescribing and the letters from the consultants that we read. We need to act on the letters from the consultants. We need to discuss them with the patients from early age so that we can carry them through transition. We need to know about their social situation. Who's looking after them? Who's looking after them 24 hours a day? Are they in foster care? Are they in adoption care? Where does the money come from? We need to know about third sector involvement. How can we support Together for Short Lives if we don't even ask the patients if they are involved with them already? We need to communicate with adolescents in a way that they can understand. And we need to communicate, as Mike has said, with their carers and their parents, accepting that those adults are going through a transition as well. They started off they could often start off looking after an infant as bright, healthy, young, athletic adults. As they are now looking after a 15 or 20-year-old young person, they could have the osteoarthritis, the hypertension, the ischemic heart disease. We need to look after them as well, and we need to take it on. And the bottom line is that there's 2 sections in the module about this, and it's important, is everybody's watched the European football. The new concept of goalkeeper sweeper, the chap at the back who watches all the players and sees how the ball is going, but stops the ball finally going in the back of the net. We need to be there to stop the ball of care going out of control, because we're the only people who can do it. And we've got a choice. We can either do it or not. If we do it, we will improve healthcare for the patients. We will prove that we are well placed to do it, and we will transfer our skills from multimorbidity and polypharmacy from the elderly that we are doing now to children. If we don't do it, we will have call after call of crisis calls from these young people and from their carers. And because we haven't gone through the training, and because we haven't got the plans, we will have great difficulty in answering them, but we will have to answer them. And there are some places where this is already been started. And Tazita has actually started it in her practice. She's looked at it. She started a register. And we'll leave it to Tazita to tell you what she's done. Because if we can each practice, each GP like one little light, then we can help all the young people in our country who deserve it to have care from childhood. As Mike said, as the health service, which I'm passionate about, was invented from cradle to adulthood. And that's what we need to do. And what Tazita's done in her practice shows it can be started. I'll leave it to you.
Thank you, Peter. So, hi, everyone. So my name is Tusitha De Silva Amarasacra, and I'm a GP in Leeds. And my role was to work with our pilot GP practices to work out what practical steps we can take in GP to help with this transition process. So this slide is going to take you through some of the steps that we took, and it will hopefully give you an idea of what this might look like at your GP practice. So the first step was to find a good mechanism, firstly, to identify these young people in your practice. So as Mike said, we're not looking at big numbers here, and I think this is important to note for workload reasons, but we're looking at roughly within a 15,000 patient practice, we'd roughly have about 2 or 3 young people transitioning at any one time. So the first step was to do some searches and identify the young people within our practice. The next step was simply to make initial contact with the young person and their family, introduce ourselves and say that we're wanting to help and support them, and to identify what areas of support they may need. The next step, I think, was to sort of discuss this with colleagues within our GP practice, and that's for 2 reasons, really. First of all, it's good to get some feedback and ideas from your colleagues at your practice about how you might take this forward. But secondly, the searches weren't infallible in identifying children, and one of the challenges that we had was actually identifying young people within our practice. So making our colleagues aware of this within our practice will allow them to then flag up to us when there is a young person that needs transition within that practice. On the same note, fostering links with our local teams. So making contact with our local transition teams, our local paediatricians, our local community paediatricians and local children's hospices is important. Firstly, again, so that these teams can flag up to us when a young person is in need of transitional support. And secondly, so that we can work closer with those teams, so that primary care and secondary care can work closer to help support these children and young people that are transitioning. As GPs, we are invited by letter to transition meetings. So particularly in very, very complex cases, we receive a letter, and so attending these meetings is also important. And I think the third point I'd like to make is that we need to be aware of other professionals and online resources. So I've just listed a list there, but it's not a complete list. There's more information in our RCGP modules. But social prescribers can be quite key. So you may have one at your practice, you may have one in your primary care network, but they can be really key and knowledgeable about community organisations that might be able to help support the young person and their family. There may be a social worker involved. The paediatric parent team is pretty key. So as Peter mentioned, looking out for their communications, but also if there are any issues that need clarifying, that need further discussion, contacting the paediatric parent team and asking. Where appropriate, adult learning disability teams can be of service when we're considering transition. Adult rehabilitation services can also be helpful for us. We've also we're going to hear from Lizzie and from Together for Short Lives, but Together for Short Lives is a really key resource to look at. It's got resources in there for patients, for professionals, for families, and it's also got a helpline available for patients as well. And to be aware of that as a resource is really important. And of course, our RCGP e-learning modules and resource hub, that's going to be key if you want to take this forward in your GP practice to learn about some of the issues that are more pertinent to GP. So thank you, and I'll hand it back to Dirk.
Thank you, Truth. So the e-learning modules we created there's 2 of them, and there's also some resources that you can use, for instance, the literature review. So there's one part is a little theoretical background, what Mike has introduced us to. The other one is the longest module we've ever had on the RCGP online learning environment. When I came to this 2 years ago, I didn't even know about the concept of transition. And the work we had over those 2 years with our steering group, with our carers, with our specialists, with our academics, with subject matter expert, with our friends from Together for Short Life, it opened up a topic for me. I wasn't aware how difficult it can be, particularly with the legal aspects and aspects around palliative care, social care. So, but don't do me a favor, and even though it's the longest we've ever had, engage with it, because Peter, who wrote the second part, has really been very practical and given us practical steps of how to plan, what to emphasize during consultation. He's done something on communication. It's an enormous, beautiful module, and please, it fits this particular complicated topic. And now I would love for the team for Together for Short Lives, and as far as I can tell, we've got Julia Hodgson, we've got Hannah Hodgson, and we've got Lizzie Chambers, and they're all going to introduce themselves.
Thanks, Dirk, and thank you so much for allowing us to have a few minutes really to talk about Together for Short Lives. We have had quite a few plugs this evening, but I'm going to be shameless and plug us a little bit more. So we're going to do a bit of a triple act this evening. So myself, I'm Lizzie Chambers, I'm Director of Programmes at Together for Short Lives. My colleague Julia, who's our Projects Manager, is going to take over halfway through, and then at the end we have a young person, Hannah Hodgson, who's going to just talk about her experience of transition. So for those of you that don't know, Together for Short Lives is the UK charity for babies, children and young people who are seriously ill and have palliative care needs. We have a whole range of support for families. We have a helpline that's been mentioned, and a whole range of kind of information, advocacy support. So really, we're there for families if you have any with these conditions and want to refer them through to us. We also provide a lot of information and support for professionals working in palliative care for young people. So we have things like a discussion forum, pathways, and a whole range of kind of networking opportunities for professionals as well. But we've had a long interest in transition, and this project, the RCGP project, is one of 10 projects that we funded through an Improving Transition programme, which Julia will talk to you a little bit more about. But we're really delighted that you've managed to complete this project in such difficult times. We've gone through a difficult year, But just wanted to say, yeah, congratulations to all the team at the RCGP. So I was just going to talk quickly through some of the challenges in transition that we've noticed, and some of these have been touched on already. But we know that in children's care, we know that children have a really wide range of kind of long-term complex conditions, some of which are really very rare, some of them which don't have a name, and that paediatric services are perhaps a bit more experienced in working with this level of complexity, where there are more kind of consultants and ologists in those conditions. But this can lead to paediatricians holding on to the children that they're caring for, whereas in adult services, they, excuse me, they tend not to be so experienced in working with young people with these kinds of conditions. And on the whole, good for generalisation, but on the whole, adult provision tends to be a bit more generic. Another issue we have in our sector is that children's hospice and palliative care is very holistic. It's from the point of diagnosis or recognition that a condition may be life-limiting. And it includes provision of short breaks as well. Whereas palliative care in the adult sector, it does tend to be more focused on end of life, which means that lots of young people that we're concerned with don't actually meet the criteria for hospice care if they're not at that point in their trajectory. The other issue, obviously, for children's care is that there needs to be attention paid to their kind of developmental development, to the things like play, sensory stimulation, education, employment, a whole raft of things, which sometimes doesn't really happen in adult palliative care. Often patients will be kind of no longer in education or employment, so it's quite a different kind of dynamic there. And obviously, as has been mentioned, GPs tend not to be involved in the care of children with life-limiting illness. It tends to be consultant-led. And I imagine in general, primary care GPs are a bit more involved in the palliative care of adults. So the impact of all of this on young people is that often young people do drop out of their treatment regimes and have quite poorly controlled symptoms if they're not engaged with early on. Often means that they are quite isolated from their friends, and they aren't able to develop relationships or to access further education or the world of work. It really impacts on the whole of their life. They also often lack choice and independence. They do sometimes end up being quite reliant on their parents, particularly those who have profound multiple learning disability. And we've had examples of young people being sort of living in care homes, basically because they have such complex needs and there's no other facility for them, which really isn't appropriate for young people. They also often miss out really on opportunities to make choices about what matters to them, or to have opportunities to discuss end-of-life care. And also, as well as the impact on young people, there's a massive impact on parents. Often parents are absolutely terrified of the transition process and that sense of falling off a cliff and of letting go of their child into that kind of wild west of adult services. So there's a real need to support parents early on and build their confidence in the system and what is there to support them. So I was at this point going to show this short film. It's about 4 minutes long. But I think we're a bit short of time. We want to make sure we've got time for questions at the end. But you can have a look at that film perhaps when the presentation is shared. I'm going to hand over to my lovely colleague, Julia.
Hello, my name's Julia Hodgson. I'm no relation to Hannah, although I have met her and she is lovely. I'd love to be a relation, but I am not related to Hannah. And just about the film, do try and watch it. It is quite dated, but what struck me as I rewatched it this week was how pertinent some of the issues are. And although it might be nearly 20 years old, it's quite depressing to think that young people are still telling us the same things, despite the fact that for the last 20 years, there's been some real effort across the sector to make things better for young people, including Together for Short Lives. And this slide just sort of captures some of the activity we've been involved in. So prior to Together for Short Lives, before we merged with Children's Hospices UK, ACT produced a guide to the needs of young people, and in 2007 developed the first transition pathway, the ACT transition pathway. This was updated in 2015, and Mike Miller referred to it earlier. It's called Stepping Up, and it's a pathway for professionals from different disciplines, supporting them identify what good practice looks like along a transition pathway. For 5 years between 2013 and 2017, we received funding to head up a transition task force where different regions set up action groups to take the issues their young people were facing locally forward, and they met and they discussed and joined together nationally to look at good practice that was happening across the country and to share some of that good practice. And although partners came together at that time, it was acknowledged that a lot of those partners were already championing good transitions, and it was a matter of talking to those who weren't attending regional action groups to make a change that needed to be addressed. And that was coupled with 2 data studies we undertook in 2013 and in the latest one in 2021. And again, I think one of Mike's slides noted that within the dates of those 2 studies, the prevalence of young adults living with life-limiting conditions facing transition rose by 40%. And in 2013, we commissioned the University of York to undertake a research project looking at young adults' experience predominantly of adult health care. So that's worth a Google if you're interested in that study as well. In 2018, you'll see the central bottom, we acquired some funding to support 10 projects, improve transitions for young people across the country. And we're delighted that Sir Alan Craft was there to chair the panel. Mike Miller was involved. So we chose 10 projects that demonstrated real potential to make a difference. Some of the outcomes involved development of resources. Some of them have produced improved well-being, reduction in costs of delivering services. And it's at this time that we're starting to really see the benefits of the hard work, particularly during COVID, that the projects undertook. Several of the projects were led by children's hospices. A couple were led by adult hospices. There was some resources led by the Open University and the Sexuality Alliance to develop guidance for professionals about talking about sexuality and relationships. And a couple of the projects were led by hospital trusts, really looking at how they can improve and capture good practice in their practice that can be shared and disseminated more widely around the country. Each of the projects undertook a local evaluation and have reported that in, and they're going to be collated and sit alongside a national evaluation of the programme that hopefully is going to be launched in early next year. Details of all the projects, and I'm just conscious of time, so skimming the surface, are available on our website. And again, once the presentation is circulated, you'll be able to click on the link and read more and access some of the resources and reports that have been developed. Also available on the Together for Short Lives websites are some of the resources that have been mentioned. Mike mentioned a checklist. So this is an electronic document, as is the moving on the top right, the moving to adult services, what to expect, both aimed at young people themselves, but can be used across a range of settings just to start that conversation about what a good transition might look like. In the centre there's Stepping Up, which is the revised transition pathway. And there's also a couple of resources on, particularly on personal budgets, how to use personal budgets, and a project we did about having difficult conversations, just sharing some experience of young people and the families themselves about the importance of professionals feeling confident to talk about end-of-life care planning. At this point, part of our work is about working alongside families and young people themselves. And I'd like to introduce you to Hannah. She's going to introduce herself, but I just want to say how grateful we are for all the support she gives us as an organisation. She's an inspiration to many and has been a young expert. We've got a group of young adults who are our young experts who support us. So without any further ado, I shall mute myself and hand over to Hannah.
I'm Hannah and I'm living with probable mitochondrial disease. It's definitely genetic, we just haven't got the full genome done yet. Transition was a very tricky time for me. I went from peds hospitals and hospice to the adult versions of them. And I turned 17 in a children's hospital, which meant overnight non-emergent surgery and over 16s wasn't allowed. And in adults had the same policy except for under 18s. So I spent 2 extra months in hospital while that was fought out. And though that isn't a community example, it's just an example of the kind of barriers. I don't have long to speak, but I thought I'd gather some examples of things which were helpful. So I know that one of the things at the front of your mind in regard to transition is safeguarding, rightfully so, and parents letting go. However, the only reason I can work when my health allows it is because my mum is my carer. She does all the medical admin, all the drawing up of meds, and helps me maintain my 4 stomas in amongst so many other things that I have going on day to day. When I was told about transition in peds, I was told that I would need to take charge completely, which instead of empowering, created a very intense fear for me. I have full capacity, and yeah, it was a battle to install my mum as the everyday person to speak to about a repeat prescription, but to involve me when we're talking about not so much everyday stuff. With my capacity, I decided I wanted to write and to speak and to do the kind of things that I love. The tipping point for me, putting my foot down, was when I was trying to phone the GP for an appointment, and we kept a tally between us. When I rang, 7 times out of 10, I was palmed off. But when my mum rang, she was only diverted twice. Continuing care is extremely difficult to get for children. I was denied 3 times. The phrase used was that continence, feeding and socialising falls under parental responsibility. It would be important to highlight to a young person that upon turning 18, those assumptions are gone. The point is, if you can't do something yourself and you're unsafe to do that alone, you may be entitled to some care because the parental assumptions disappear. My adult district nurses are not trained on educational healthcare plans, so I remained under community peds until I was 19, which was an absolute cut-off. I had to go to adults at that point, despite EHCPs being an option for up to 25-year-olds. If I went back in education today, they wouldn't be able to help me initiate such a plan. Alongside this, there's a need for age-appropriate resources when it comes to writing of a living will and acknowledgement of the pertinence of power of attorney, because these things come up very fast when your condition's degenerative. I'm just going to close with a poem that I wrote upon learning what the label palliative meant once I was given it and relearning my assumptions. Little deaths. After the death of my stomach, the church was full of mourners. But at the 15th funeral of myself, it's just me and a few doctors. We lay wreaths by each ear, and seal each urn with a hearing aid mould. I am a widower grieving herself, my stem still living while all the petals have died, and this body has begun to droop. Thank you.
Thank you, Hannah. And thank you for coming to share this with us. And yes, it opens up such a can of worms in which every general practitioner just now sits at home in front of the screen and goes, goodness, what would I have done? Or did we do the right documentation? Did we have this on the front screen, on the home screen, that mum is allowed to answer all health-related questions, make decisions around repeat prescriptions? I hope that the module is detailed enough that we are giving some advice in future for general practitioners who, like me, have never thought about this. Okay, and yes, you're absolutely right. Safeguarding is often at the forefront, and yes, and probably none of us has ever thought about that. Being concerned about safeguard can have actually negative impact on the patient. So, hey, you've opened up our minds already. So actually, this is a little bit about documentation. When I've learned one thing over the 2 years, which is probably one of the most important things, apart from our being a GP, and is what we do, is code properly. If you don't code properly, you will not pick up the patients that you need to. So make sure that the letters that are coming in from hospital are being coded appropriately. So we know that this is a person with a complex or a life-limiting illness. So if you run an audit trying to find these patients to invite for discussions around transition, otherwise they will not be present to you. I've done a similar exercise as Tushita, and I similarly had need to really expand the search until I found patients who would fit the criteria, and that was so rewarding because actually, yes, they haven't had any much contact with general practice, but we have questions. So I'm very honored to have the wonderful Hilary Cass OBE asking a question to us. And she asks, knowing the volume of correspondence that we get as GPs in general practice, how can we provide the most useful information at the right time in the right way for you to gradually take over responsibility? I'm going to ask Peter to answer that, and Tus, I can just say from my point of view, pick up the phone and call me. If I'm too busy because I'm in a consultation, I promise you I'll call you back. I've never in my life not called a consultant back if they want to discuss a patient. Alternatively, ask for the practice's email address and fire off quick email to the practice. Can you please let Dirk know that I would love to talk to him? You don't have to put patient details. If a consultant sends me an email to ask to call him, I'll call them back within 12 hours, trust me. So from my point of view, email, phone call, or even maybe at the end of your letters, which are lovely from the pediatric departments, in bold, GP, can you please give me a call so we can discuss this further, because this person is now coming up to difficult decisions in their life and is going into transition. Just give us a call. This is my email. This is my email address. Peter, you might have a different opinion.
No, I agree entirely about the communication. But again, above that, you might have noticed a certain passionate cry that we need to make sure that general practice appreciates its responsibilities with regards to educating itself about childhood problems. And I think the situation where children are referred in early life to a paediatric team, and then as Mike said, it gets the situation where all intercurrent problems then left under the paediatricians. I think there needs to be an interchange of opinions between general practice and secondary care, and we need to break down the barriers. Yeah, increase the telephone calls, increase the number of emails, and increase the learning, basically, of the general practitioners. And we have got a fantastic book, because your speciality is neurodisability, written by two colleagues that I worked with in Leeds on neurodisability. And they have written the book, which is it's totally suitable for general practitioners. So if they do have a problem like Hannah, who everything she says, I agree with. The palliative care situation, it's crazy that in this country, it's not funded centrally and there's not planned. So that what's provided by palliative care in each area varies. The benefit situation, GPs under the financial records, we need to make sure that we support people through that. The prescribing situation, I've been dealing today with a family who've been desperate to get a prescription. Simply to get a prescription from the GP that was prescribed by secondary care. We need to break down those barriers, not in a month, not in a year, but now. It's more costly for the family to travel to a hospital to get the same medicine and make it more expensive than it goes to the GP. We need to break down those barriers. And this understanding of the teenager and the young person. Anybody who has seen Hannah and her mum together will know that whichever one of them rings up, it doesn't actually matter, right? Because they're actually both on the same side. So how can you query anything? If Hannah thought that there was something confidential she didn't want the mum to know, she's got the option of saying, I am a young person, by the way, this bit I want excluding from my mum, and she can do that. But we should know that those two, that young person and her carer, are working together. And I'm sure Thus has got some good ideas in everywhere.
Yeah, I think I'd agree with everything that's been said. Just highlighting in when particularly, age 14 at the latest, when we're starting to think about transition, highlighting that in letters to us. It's interesting that Peter says that we should already know as GPs if a young how a young person communicates. What I found when I was reviewing the notes was that actually when I was coming to contact the first young person and family, I was thinking, I'm not actually sure whether this young person can communicate with me. I wasn't sure of whether or not that young person could answer the phone. So I didn't know whether or not I should be calling the young person. So I think ideally we'll get to a point, as Peter says, where we'll already know that information. But sometimes in answer to the question about the communication, I think that might be quite important to put in the communication at this point. This is this is this patient's communication, this is this young person's capacity, how this person might like to be addressed. That's actually quite important as well to put in communication, I found, when doing this project.
A question for our friends from Together for Short Lives, please. What role for patient-held records to support complex care and transition? Do you have any experience from the people you work with?
I'll answer that if you like, Julia. I think that is really important. We actually produced a care transfer document which young people can use themselves, particularly when they're going into a hospital setting, possibly for the first time, when perhaps the implications of their condition may not be kind of obvious, and they need to sort of just set out their care needs for those supporting them. So I think it's really important. I'd be quite keen to hear Hannah's thoughts on that as well.
Because I've got a capacity, I have got access to my GP records live, and that has been a game changer in preventing me from getting more seriously unwell. So an example from last week was my potassium was quite low, and when that happens, my muscles start to contract and I can feel it in my body, whereas normally that wouldn't be treated because it was borderline. Because I was having symptoms, it was acted upon, and if I didn't have access to those notes, it wouldn't have happened. So as a patient, it was quite important for me to realise that I could have that access to my notes and that kind of conversation. And I think everything moving online has really helped to make it feel less intimidating, especially with consultants. And I mean, all my consultants are great, but especially when you're meeting a new one, or, you know, you're in your own safe space, you're at home and you're kind of more comfortable and not on the spot in the same way. So yeah, I think I answered the question quite effectively, but yeah.
Julia, did you want to come in there, or are we going to the next question?
I would just sort of draw people's attention, as Lizzie's done, to My Care Transfer, which is available on our website. That was written because so many young people were saying sometimes when we're admitted or meet new healthcare professionals, they see us as our worst, so they don't know actually what our good looks like, and their good might be quite well, they might be quite able, but for some of them, even when they're at the very best, they still have problems communicating or moving. And there's nothing worse when you're feeling really unwell to be lifted in the wrong way or to be uncomfortable and not be able to express yourself. So yeah, look out for that one.
Yeah,
nice one.
I think that actually that's the kind of document that we could introduce to general practice as well. I don't think we've thought of showing it to general practitioners, but I think it could be useful for if the GP's not seen them for a while. Yeah,
we have documentation on this on the resources section within the module. So if you want to read up or actually print out one of those, it's all in the module. Thanks to our friends in Together Should Lives, they've highlighted that for us. 2 questions, and probably that's going to be the last ones. And they're in a similar vein from Nina, who is a transition nurse in a district general hospital, who would like to know how we engage general practitioners en masse. My personal opinion, that would make sure that we know you exist, because I wouldn't know whether there is somebody at my local hospital, whether there is a transition nurse. So either actually calling a few general practices and maybe speak to their to the lead palliative nurse as a starter. If you can't get hold of the general practitioner who leads in palliative care, send them an email, maybe a personalized email to the senior partner, which will be read if it comes from a clinician. Don't know whether, Tus, do you have a similar idea?
I think we sort of discussed it a little bit already in terms of, you know, communication via letters. You mentioned emails. I think picking up the phone as well, if there's something particularly urgent, you know, more often than not, you know, each GP practice will have some way to, you know, that if there's an on-call GP that they can deal with, if there's any particularly urgent queries, or, you know, if there's something that's less urgent, then, you know, that can be communicated via, you know, email or letter. But generally, you know, that will normally get picked up. You know, if it's highlighted, and I think just made clear in action plans in bold at the bottom of letters. And
just make sure that we know that you exist. So yes, please send a few mails to the senior partners or the palliative leads in your vicinity, in your patch, and let us know. And I'm sure that there were loads of people who would love to engage with you. Joe Elverson asked, hi Joe, how if the person doesn't have a named GP, how do we engage with them? Doesn't matter. If it doesn't have a named GP, engage with the lead palliative GP or the lead palliative nurse, or whoever runs the MDT. It could be an admin person who runs the MDT. Engage with any of those 3 and you will have immediate impact, because you will be heard and the patient's care will improve.
I think it's a good idea to have one person within the practice who's leading on this, and who's taking sort of leadership and sort of taking ownership for this within the practice. And that's where it becomes important to communicate about this project within your GP practice, including your practice manager and your admin staff, because then they'll become aware that, oh, there's some communication that's pertinent to transition, And then if there's somebody leading on this within your practice, that can provide some continuity as well. I think within each practice, leadership and ownership needs to take place within that.
As I said before, we've been doing this forever, but now we're trying to do it more structured, starting a bit earlier, so people like Hannah don't have to battle with us for years and years. And then hopefully it's easier for us as well to help our patients on this pathway. It's 8:05. I'm going to finish the webinar for tonight. I would like to thank all the panelists for tonight's presence. So Hannah, Julia, Lizzie, thank you so much for helping us over the last 2 years to make this a reality. Your input was amazing. Mike and Peter, wonderful authors to work with. Tus, you're the best co-worker one could hope for in a context like this. And Haley, who we can't see, and he's in the background and running all the technical stuff. Have a lovely evening. Bye, everybody.